So the July 2020 MEC Minute is about behavioral emergencies. And in this conversation, we're going to talk some about behavioral emergencies and our treatment algorithms. We're going to also review our clinical standard on the use of restraints. Toward the end of the conversation, I'm going to have a brief discussion about that EMS law enforcement interface when dealing with behavioral emergencies. It's not going to be a long discussion because politics is local, and your interface with law enforcement depends on your situation. Whether you work for the city and you have a city police department, or if you're working for a township and you have the sheriff's department to deal with, you have to know law enforcement. You have to have some sense of how you're going to interact with them, and I'll briefly discuss that toward the end. I also want to talk a little bit about excited delirium. Excited delirium is a condition which really wasn't recognized 20 years ago. It's become more prevalent as a diagnosis. The original talk about excited delirium actually came from the medical examiners, the coroner's offices across the country. They talk about these patients who were wildly excited, uncontrollable with abnormal behavior, and then suffered a cardiac arrest, typically while under the custody of police. So excited delirium actually started in the world of medical examiners, and now more and more is being recognized as an acute psychiatric emergency that requires immediate intervention in order to calm the patient and treat their underlying circumstance. So why are we having this topic for discussion now? Well, I think we're all seeing an increase in behavioral emergencies. I know that our utilization of ketamine has gone up over the years since we started using it for behavioral emergencies. There's also been recent increased scrutiny of law enforcement agencies and how law enforcement interfaces with the public, and we see the videos either from the police body cameras or from cell phone videos and so on. And I think sooner or later all of the scrutiny is going to drift into EMS and how how we interface with patients who are having behavioral emergencies. And with behavioral emergencies, usually law enforcement goes in to secure the scene. So there's that opportunity or risk that EMS and our behavior and our actions managing behavioral emergencies starts to become more scrutinized by the public. There was a recent article published by NBC News about Aurora, Colorado, and a patient being taken into custody, and how the patient was treated with ketamine, and a lot of controversy over whether or not the patient even received the ketamine. It's readily apparent if you review the article that the patient was given too much ketamine by the EMS providers, but that in itself is a whole different conversation. But I think there's that risk. And I think we also think about, if law enforcement's under increased scrutiny, might law enforcement start deferring some care management, some management of the event of this unruly patient to EMS, where EMS can treat the patient medically, and reducing the likelihood that law enforcement needs to use significant restraint or something else that may be poorly perceived by the public. I think sometimes we have to think about, is this patient's behavior or conduct? And I'm going to use the word behavior, or try to use the word behavior when I think there may be a psychiatric or psychological issue at play, or a medical issue at play, and conduct to indicate that the patient's just exhibiting violent actions that have to do with how they relate with the cops or with people in general. But I think it's often difficult to talk about or to determine, is this patient a behavioral health issue, or is this patient who's got violent conduct that needs to be managed by the cops? And I think we also need to talk some about excited delirium. It is dangerous. It's a life threat to the patient and to a risk to injuries of others. So I just want to spend a couple slides about excited delirium and how we manage it. There are a couple absolutes about how we manage patients with behavioral emergencies. Patient and provider safety is paramount. That's true for any episode of patient care. We have to think about our safety. We have to think about the safety of the patient. We are not going to do something that unrealistically jeopardizes the health and safety of any of us. We sedate and or restrain patients in order to safely manage a patient who has a behavioral emergency. We use sedation to protect medical devices such as nasogastric tubes, endotracheal tubes, peripheral IVs, Foley catheters, but we will use restraint and or sedation to protect those devices. And we use sedation to make patients unaware before or after procedures. So we use sedation to make somebody unaware as we are intubating them, or make them unaware as we are performing a painful procedure such as a joint reduction. If somebody just wants to fight with the cops or just wants to be violent, and you have no indication that this is a psychological emergency, then that's law enforcement's dilemma. It's up to law enforcement to control the patient and to restrain the patient and to manage the patient. Sometimes we just can't tell. Is this patient violent because it's their means of conduct or responding to a situation that they perceive putting themselves at risk? They don't want to be taken into custody, so they fight. Or they are in an altercation with somebody else, so they fight. Or is this patient truly suffering from a psychiatric emergency, in which case they are our patient to manage, and when in doubt, we treat the patient as a patient, or we treat the person as a patient. Get the patient safe, get them sedated if you have to, get them to the hospital, let the hospital determine whether or not the patient's behavior is due to a psychiatric emergency. So what is a psychiatric emergency? So, is this a psychiatric emergency, or is this just a bad dude that wants to fight? A psychiatric emergency, by definition, I've seen, is an acute disturbance of behavior, thought, or mood, which, if untreated, may lead to harm either to the individual or to others in the environment. So, again, this is an acute disturbance of behavior, thought, or mood. It's a psychological issue. It's not a bad conduct or bad behavior issue simply because the guy doesn't, or the person doesn't want to be controlled for some reason. Some helpful hints in terms of a psychiatric illness or behavioral emergency versus a violent conduct. Look at the history. Has the person had a violent or a recent crisis? Have they had a toxic exposure? Many of our psychiatric patients have a concurrent chemical dependency issue. Has this person been taking alcohol? Have they had recent emotional trauma? Maybe they had a spouse die, a breakup with a girlfriend, boyfriend. Are they exhibiting any suicidal or homicidal thoughts or behavior? Have they had previous psychiatric or medical problems, and are they on any medications that suggest they may have a psychiatric issue? So if you have a patient who's acting badly, and somebody tells you that they are on a psychiatric medication, well, then it's a good likelihood that they've got an exacerbation of their psychiatric illness. They need medical help. They need your time and attention. Some objective findings, look at the general appearance. Are they well groomed? Are they disheveled? Are they debilitated? Are they bizarrely dressed? Do they have makeup on that just doesn't make sense? Look at their vital signs. I know if I'm in custody or being confronted by a police officer, my pulse rate's going to go up, but I don't think my pulse rate's going to be 130, and my blood pressure 180 over whatever. Is there something to suggest that they're under influence of a chemical such as cocaine or amphetamine or any of the other stimulants, any of the sympathomimetics? Do they have a medical alert tag on that indicates they have a medical condition? And it's not just, do they have a medical condition like a psychiatric illness? Could they have another medical issue like diabetes where they're hypoglycemic and now they're acting bizarrely? Or maybe they've had a seizure and now they're acting bizarrely. Columbus published some data early in the course of our use of ketamine, and they looked at the indications for the ketamine, and they looked at the diagnosis for the patient after discharge from the hospital, and more than 50% of the patients who received ketamine by EMS were discharged from the hospital with a diagnosis of seizure disorder. So the patients are acting bizarrely and violent, but they were post-ictal, and that's why they were acting that way. So look for the medical alert tags. And then get some idea of how the patient relates to reality. I mean, if patient is oriented, they know who they are, where they are, they're not hallucinating, you do a quick mental status exam and they seem to be appropriate, then that's more likely to suggest that maybe they're having an issue with bad conduct, bad behavior, because of that's not related to a psychiatric illness. And then just from a behavior perspective, think about those things that may predict or increase the likelihood the patient is having problems psychiatrically and is as at risk to exhibit violent behavior. Males tend to be more violent with psychiatric illness. If the patient is intoxicated, whether male or female, they're more likely to be violent. Think about, does the patient show paranoia or unrealistic aggressiveness, or threatening behavior or threatening language. And this doesn't need to be directly focused at you. It could be the spouse who says, boy, they're just acting violent lately. They're typically calm, now they're violent, now they're threatening. I talked with one of the medics yesterday, and they had a patient who his wife called because he was aggressive at home, and he was exhibiting aggressive behavior like slamming doors, slamming the refrigerator, vocalizing loudly when he typically doesn't behave that way. Well, those are things that might suggest there's a psychiatric illness at play. I'd like to move on now to excited delirium. Excited delirium is considered a syndrome. It's really a syndrome where the patient exhibits this severe psychomotor agitation. They're agitated, they can be pacing, they can be violent, they can show evidence of delirium, this unrealistic thought, and they typically are sweating and maybe diaphoretic. Typically it's related to either stimulant use or overuse, such as amphetamines or cocaine, or some underlying psychiatric issue. But my experience is typically it's a combination of the two. The patient has some underlying psychiatric illness. They are using or start using a stimulant or excessively use a stimulant, and now they're exhibiting this bizarre behavior. So symptoms of ED or XD, it could be paranoia, disorientation, extreme aggressiveness, combativeness. Typically these patients, you can't get them to sit down. They're pacing, they're moving around, they're constantly in motion. They have tachycardia, they can be hallucinating. They typically are tremendously diaphoretic. They're sweating like crazy. Their speech may not make sense. It may be pressured, meaning that may just be rattling on faster than you can understand. These patients typically, if confronted or there's attempts to restrain, can show unexpected strength, similar to PCP. I mean, you look at these patients and they're relatively small. They don't look well muscled, but they can be throwing the security guards around the room. Typically, these patients are hyperthermic, so once we get them controlled, we find out that they're hyperthermic by getting a temperature on them. And often they start taking their clothes off because they feel hot. They are hyperthermic, they feel hot, and they're taking clothes off in order to try to reduce their body heat. Key signs to make the diagnosis or to have that impression are unrealistic and extreme aggression, an altered level of consciousness with associated diaphoresis and hyperthermia. Those are kind of the key points. Some things that may mimic this, one of them is mania, somebody who has underlying bipolar disease, and now they're in that manic phase, and they're just agitated with pressured speech. They're pacing around the room. They won't sit still. So mania is one of them, but typically the mania patients don't exhibit the aggression and the combativeness. They're not tachycardic. They're not hyperthermic. They're not sweating, and typically don't have to worry about restraining them, so you don't have some assessment of what their strength is like. Another condition is neuroleptic malignant syndrome. It's out there. It's rare. It's associated with use of the earlier antipsychotics like Thorazine, Haldol, droperidol. You can also see it with Compazine and Phenergan, which we primarily use as antiemetics, but if patients are on them for a long period of time. Typically, patients are on these medications for at least 1 to 4 weeks before they develop symptoms, and the neuroleptic malignant syndrome can be life-threatening if not aggressively managed and treated. Typically, they have fever, tachycardia, sweats. The things that may differentiate neuroleptic malignant syndrome from excited delirium is muscle rigidity and salivation. This is something that I have seen maybe less than half a dozen cases in my career, but I think for you, the important thing is to understand it may be a cause, think about their medication history, but in terms of treatment, we use the same medications for neuroleptic malignant syndrome as we do for excited delirium. So you're okay there. Hypoglycemia, though, is also an issue, so if you have a patient who is agitated, excited, diaphoretic, get a blood sugar as soon as you reasonably can. Most of the time they're not going to be hypoglycemic, but you have to think about it. I always tell the guys you can't do too many blood sugars. If you have any concern for possible diabetes, check a finger stick. And the last thing that comes on the list of things to think about is a thyroid storm, which is where you have an overactive thyroid gland, and it's more than just an overactive thyroid. It's the thyroid levels are so high the patient is just tachycardic, diaphoretic. They can be manic. I mean, it's not a diagnosis you're going to make in the field, but it's there as a possibility. So for excited delirium, there are complications. You know, the biggest complication we think about is death. There's a mortality rate that's less than 10%, but it exists. It's usually from a cardiac arrest. These are the patients that we may hear about where they're being taken into custody by law enforcement. They may be restrained, they may be tasered, and then they suffer sudden cardiac death. It's possible that these patients are suffering from excited delirium. Another complication is rhabdomyolysis. So it's something that you can think about, be aware about. We don't expect you to treat it in the field. For excited delirium, the treatment is ketamine or Haldol or Versed, midazolam, which pick your poison. For us, it's going to be ketamine and midazolam. And then if these patients are hyperthermic, we need to cool them down. So that could be undressing the patient, ice packs on the armpits and the groin. It could be some cool misting and spraying of the patient, whatever it takes to cool the patient down. IV fluids, if the patient has rhabdo, we're also going to give them sodium bicarb. That's not something we would expect you to do in the field, but if you're worried about excited delirium and the patient's tachycardic, you get them sedated well enough, you get an IV started, I would think about giving them a fluid bolus. So we talk about behavioral emergencies in general, and that would include excited delirium. Scene safety is always paramount. We can attempt to do verbal de-escalation. I can tell you if you have a patient with excited delirium, verbal de-escalation isn't going to work, but you'll find that out in the first 30 seconds of your interaction with the patient. We have to think about potential causes again. Think about those psychiatric mimics like hypoglycemia, seizure disorder, or acute intoxication with drug and or alcohol. And then for our treatment, we're going to medicate based and restrain as per our protocol. So if you look at how we treat patients with psychiatric emergencies, I got a list of the drugs that we commonly use. In the emergency department, some of us will use something called Haldol or haloperidol or droperidol. These are two antipsychotics, and we can mix them with benzo, which could be Ativan or Versed, and Benadryl. Sometimes we'll call that a B52, which is basically Haldol, Benadryl, and benzo, which is Ativan. Another option is Geodon. It's a good antipsychotic. It can be given both orally and as an intramuscular injection, and we do use it in the emergency department, but it usually takes 15 to 30 minutes to show its effect. The other option that we use is ketamine with or without benzodiazepines. That's what we use, and that's what I think is the best option for us. So we use ketamine and Versed because it's fast, it's relatively safe. If you dose it appropriately, patients typically do very well, but we still need to provide cardiac monitoring and capnography if we give the patients these meds. It's generally good for all ages and all sizes, so we can adjust the medications based on weight. And we have these medications because we can use them for other indications. So if we need to intubate the patient, we're going to provide additional meds for pain control. Or if the patient may have neuroleptic malignant syndrome, these two meds work well for these indications as well. So, we try to minimize the number of medications on our drug license. There's really no reason to add Haldol or Geodon to our drug license when we've got ketamine and Versed, and we can use ketamine and Versed for more than one reason. So that's why we chose these medications. We have our protocol for behavioral emergencies. If you look at it in this on the left side of the algorithm for adults, there's a discussion about excited delirium. It gives you some guidance in terms of symptoms and so on. I'd like to remind you that when you look at the protocol on the bottom, and this is true for children as well as for adults, we have two arms. So if the patient is just agitated, they're pacing, they're anxious, but they're controllable, and you want to just help them get over the rough spot, well, then we use Versed or midazolam. If the patient is violent or combative, and you think they are suffering a psychiatric emergency, then we're going to use ketamine. And if we use ketamine, we also co-administer midazolam. We co-administer midazolam because ketamine can cause withdrawal phenomenon or awakening phenomenon where the patient has bizarre hallucinations. The benzo helps reduce that. I think we're probably one of the few entities in Central Ohio that gives Versed with ketamine. Many of the other protocols across the city use ketamine alone. We are starting to have conversations among the EMS medical directors about our behavioral protocols, and we are doing a gap analysis to see if we might come up with a consistent protocol for medication use in behavioral emergencies in Central Ohio, or at least in the Metro Columbus area. More to come on that. Again, we have the violent combative patient versus the agitated patient. You pick the arm. If the patient just needs to be calmed down a little bit, use the Ativan. Not everybody needs to get the dart with ketamine in it. We also have the pediatric protocol. It's very similar to the adult. Again, we have the two arms to it. We have sedation for the agitated patient with Versed, and then we have the arm that gives you ketamine. With the ketamine for children, if the child is 12 years of age or older, we're going to then co-administer midazolam. If you have a behavioral issue with the child and they're under age 12, they don't need the Versed, just give them the ketamine based on the weight dose. So that's probably the biggest difference between the pediatric and the adult protocol. When I mentioned earlier that we're seeing more psychiatric runs, more behavioral runs, I think the most impressive thing to me is we're seeing more children with behavioral emergencies, and we're giving children of what I would consider relatively young age ketamine because they are uncontrollable. I'm worried about what's happening with our children. I would not be surprised if we take another look at our use of sedatives, particularly ketamine in children, over the coming years as we see what comes out of Nationwide Children's with their behavioral unit. I just want to talk a bit about our clinical standard on restraints. It is in the book. Please review it. And this is probably the source of greatest concern when we have an interface with law enforcement. We use restraint to keep the patient or ourselves safe. Law enforcement has the ability to do certain things that we do not do. We do not use handcuffs. We do not hogtie patients. That is really one of the reasons we should have a conversation with the cops. There's also an expectation that if the patient is in handcuffs, an officer accompany you in the back of the truck. I realize that for some jurisdictions that may be difficult, but if the patient's in handcuffs, that means they're a ward of the police officer, and that police officer is responsible for those handcuffs. And if there's an issue, something happens in the truck, we need to be able to get those cuffs off, keep the patient safe, and take care of business. So we really want a law enforcement officer in the back of the truck. The other thing is if you're talking about a TEMS unit, a TEMS response, and the TEMS medic is in the hot zone, all bets are off. Do what you can to keep everybody safe, but that's a different discussion for the TEMS medics. So what kind of restraint do we use? Well, we can use verbal de-escalation, keep the patient calm, do what you can to calm the patient down. Again, don't expect this to work if the patient has excited delirium. We use chemical restraints such as ketamine and Versed. My preference is that we use chemical restraints if at all possible and minimize the amount of physical restraints. And I would, especially advocate for Versed to calm the patient down who's just a little bit agitated, so you don't have to use ankle straps, wrist straps, or a posy vest. If we have to use restraints, we keep the patient in the recovery position on their back or their head elevated a little bit so they can breathe more comfortably. We don't transport them face down or hogtied. What restraints are inappropriate for us? We do not use chemical paralysis and intubation to restrain a patient. I know in years past, decades ago, some of my partners in the emergency department at a different practice location were known to paralyze and sedate patients who were behavioral issues. We just don't do that. But admittedly, in those days, we didn't use ketamine like we do now. Again, we don't hog-tie the patient. It's been shown that hog-tying a patient significantly impairs the patient's ability to breathe. Our goal is to keep the patient breathing normally so we don't have to worry about airway interventions. We do not use handcuffs, we do not use tasers, or other methods of restraint that may be utilized by law enforcement. So keep that in mind. Discuss with your crews how you might manage your unruly patient. The last comment is, last slide really has to do with that EMS law enforcement officer interface. You know, that interface varies based upon locality. Some of our member agencies are part of a city system that has law enforcement as well. Many of us have agencies that have relationships with the sheriff, and then we have some agencies that may have to deal with city police, township police, and sheriff's office. So we need to think about, you know, what the relationships are with law enforcement, know your law enforcement officers, and talk locally about how you're going to interface with law enforcement when you manage or are dispatched on a behavioral run. I think the first thing is to make sure the scene is safe, make sure the patient does not have weapons, and then get involved with the patient, do your assessment, and so on. We do not use chemical restraint to help law enforcement get a patient into custody. We use chemical restraint because the patient has an acute psychiatric issue, or we think they have an acute psychiatric issue. They need chemical restraint in order to be safely transported to a healthcare facility where they can receive an appropriate assessment. So, you know, politics are local. Have these conversations within your fire administration. Have these discussions with law enforcement locally. Make sure you have some understanding of each other's boundaries in terms of what you should or shouldn't do, or can and cannot do as you respond to these behavioral emergencies. That's all I have. If you have any questions, please send me an email or post it on Workplace. Hopefully, I've given you some additional information you can use in the field. Keep yourself safe and do what you can to stay out of the eyes of the media. Thank you.